Order, order. Welcome to the Health and Social Care Select Committee, this one-off hearing on the Casey Commission, and we're going to get cracking. So I would first start by asking our first panel of witnesses to introduce who they are and what they do. And please could we start with Baroness Casey, please?
Louise Casey, and I chair the Commission, the Independent Commission on Social Care. Thank you for being with us today.
Thank you.
And I'm Sarah Coscarin. I'm Deputy Director at the Casey Commission on Social Care.
Well, thank you both for coming. First question. Louise, have you spoken to Andy Burnham yet?
Yes, I have spoken to Andy Burnham yet, both before, during and where we are now. I mean, as you are probably aware, he's not the Prime Minister yet.
No.
And he obviously did an awful lot of work on social care in Manchester. So we'd already been up to Manchester and talked social care months ago. And then I think he was going to say something in the run-up to something or other, I think a Guardian article, and his team got in touch. And we sort of said, yes, you can say whatever you want to say. We're not influencing it. It's entirely a matter for you. And then, like everybody in the country right now, I will await the outcome of the next few weeks and see who the next leader of the Labour Party is and therefore who the new Prime Minister is.
Well, if he wanted to expedite the process, is that something you'd be able to do?
Yes. Well, I think the key thing here, and I think we've discussed this before, is that there's a the most important word when you're agreeing terms of reference is the words are very important. And it says by 2028. There's a person sat behind me very carefully made sure it said by 2028, giving us the ability, which I've always said, and actually ministers have always been incredibly supportive of the fact that if we can bring the overall piece of work in earlier, we should. And also they were very keen, the previous Health Secretary, the current Health Secretary, and the Minister for Social Care have been really keen from the outset. What can we do as we go along the journey? So what changes can be made now? What changes could we make ahead of any general election, and to set out the stall for what could happen potentially in the future, and to use cross-party talks as a way of trying to manage those processes in parallel.
Thank you. And just very briefly, because we are going to go into all of those different aspects with different questions over the next hour, where are we right now? So how far along in this process have you got?
Well, we've done, as colleagues I hope know, we've done a huge amount of work, and I am actually going to have to take my jacket off.
By all means, please.
I put it on thinking it was the polite thing to do at a select committee.
No.
And I don't think I've ever done a select committee without having some form of a jacket on, but I'm struggling. So, so where we are is we've done, I think, a huge amount of consultation. And we could probably go into the detail of that if people wanted to. We have had 2 cross-party talks. We have visited and got alongside in the constituencies of members that represent social care and health in their constituencies and tried to understand that. We've done a lot of work. I made a speech in March that set out, and I'm not going to make many speeches throughout this process, but I deliberately talked in March because we felt that we were ready to essentially agree with the department and with ministers on 3 particular pieces of work, which I can go into if you want me to.
Not just yet. We'll come back yes,
to it.
If that's all right. Just a brief overview would be helpful.
Then I think as we head into the summer, we are at the stage of the one part, and again I'm sure it will come up, is if I was to look back, Chair, over, certainly we've looked in detail at the last 22 reviews, white papers, green papers, commissions since 1997 alone, so that doesn't account for all of the attempts before that. One of the things that has been missing on quite a significant scale is a sort of reset of the discussion with the public, and to have a conversation with the public which is two-way on what their appetite is for, I suppose, a renegotiation of the social contract. And in order to do that, we are about to, probably giving more away right now than I should do, but we hope in July we will commence that process. in quite a big and deliberative fashion. And I think that will help us guide the next phase of what the reform looks like. It doesn't mean to say that by the end of this year, at the latest, and again, Stephen, the Minister of State for Social Care behind me, is very, very clear that if we want to move faster on certain elements, we will do. So we do intend to publish a report in this year outlining what changes we think could be made, and not wait. Not wait. And some of those are quite big, and I can go into some of the thought processes behind them.
Absolutely, we're delighted to hear that. Paulette Hamilton, please.
Good morning, Baroness Casey. My question is around the National Care Commission. Now, I want to read back to you some of the words that you used just before it all started. You actually said the Commission has been tasked with setting out a plan to implement a national care service in the first phase. This was actually a government manifesto. And what was said, sorry, this is the wrong bit of it. What was said that I want you to, have I got my questions wrong? No, I haven't. Simon Botley actually said, and he's a senior fellow of in social care at the King's Fund. He suggested that the government was yet to develop a definition of what social care was. And my first question to you is, what is your understanding of a national care service?
So I think that first of all, that's Simon Botley from the King's Fund, which is one of the many sort of think tanks and institutions that have done good work over the years looking at the issue primarily of health, but also of social care. And I think that they would probably agree with us that essentially the thing that is missing in all of this is, what does the public think social care is? And I think that there is a real fault line between what the National Health Service does and thinks about social care, and then what the rest of us do and think about social care, where most of the time we are thinking that that is local government. But actually, it is not just local government, it is individuals, families, carers. It is a massive amount of the private sector. So the whole landscape of what people call social care is often provided by the lowest paid, most uncertain level of delivery I've ever come across in my career, in terms of delivering a public service in a rather complicated way. And what that means is, to get something that you might call a national care service, we are so far away from what that is at the moment, that I think we should, there are some things that we should be doing in the short term, but we should be thinking about what type of reform is needed in, the Commission is looking at England, but I would say in this country, that takes us not just to the first quarter of the 21st century, but the first, we should be looking at 2050 and onwards to think, so what does that look like? And therefore, in scope, has to be looking at where is the NHS in that. So if I can just jump straight into it, I was really pleased when I saw that this select committee had made absolutely clear that you do not think that the removal of local government and other key partners like GPs from the governance of integrated care boards says to me that there's a real mixed message between trying to create something which is probably a national health and care service. Just
moving you on, because some of my colleagues
can talk for Britain.
No, you're not talking for Britain.
I do. I blather on.
They will delve deeper into that.
Do stop me.
So the question I want to ask you, because of what you've just explained, do you feel that a national care service is possible? Because it seems quite fragmented. Do you feel that this could actually be pulled together?
Yes, I mean, when people are in government, they can pretty much do anything that they want to do. That's kind of the gift of government, is the ability to make change and get things done. So it is not beyond the wit of anybody, including previous governments, to have set out what a national care service would look like. My view is that you can't do that unless you work out what the National Health Service is providing and where care fits within that or alongside it.
So, moving you on now, this is a bit I got mixed up, so I've got it right now. You talked about in a speech last year, it was widely advertised, that you argued that social care needs to be a moment of reckoning, as the service does not have national consensus, it needed a mandate, and it needed its own creation, like the NHS. So with this lack of clarity in mind and with the structural changes that are needed, what do you think that we may need in addition to what you're doing to actually implement a national care service?
I think the biggest thing that we now need to do is actually engage directly with the public about what a national health and care service would look like and what their appetite is for their role in that. So what do we expect from families? What do we expect of individuals? And I don't just mean financially, I mean generally, and what the deal is really between, when it comes to particularly social care, the appetite of the public to pay differently and or do differently. We were in the Whittington in London not that long ago on what we would have called in the old days a geriatrics ward. And now it's called something much nicer than that probably. But I was really struck by this extraordinary consultant there, Clarissa Murdoch, who said, we were standing in her ward and she said, families that are supporting people on my ward are looking at people that have very severe dementia and other frailties, possibly for a decade. That is very, very different to, say, 20 years ago, when those same human beings, frankly, may not have lived for that length of time. So what we're asking families and individuals, and I say this as somebody that's quite frightened, the biggest thing that we're all frightened of is dementia. And I think that it's one of the things that people worry about significantly more than I think the public, the sort of discourse in policy circles realises.
Baroness Casey, just
right.
moving you on slightly. Sorry, I've only got a short space of time.
Go for it.
You've made some really excellent points, but another point I'd like to bring to you is how far will your phase 1 recommendations go in defining a national health and care service and people's entitlements?
So I think that's a very good place to start, and I think we will look at the issue of assessment and entitlements. So I think at the moment what isn't laid out clearly, and we will lay it out clearly, is what the public can understand social care to be. Like there isn't even, an easy website you can tap into that's run by the government that says this is what's going to happen, this is what it is. Some days I think to myself we'd be better off saying to the public, certainly in England, you won't get any financial support until you're down to £23,500, at which point it'll kick in. Do you know what I mean? We don't even tell them, because I think we're a bit guilty about that. There isn't a very clear way that we tell the public what it is, when it will happen, and how it will happen.
So for me,
the answer is yes, we will do that this year.
Brilliant. But my last question is, I was a nurse for over 25 years. I've just recently given up my registration. And what has shocked me is, between health and care, as a nurse, I had no idea what happened in care. It was only when I became the head of social care, I had the governance role in Birmingham City Council, it became so obvious that this health and care service was so needed. If you give me 2 things, because I do like this as a last question, 2 things that you think need to happen to ensure that in this first stage, in this first phase, people actually understand the differences?
Well, I think the thing is, it's not for the public to understand the differences. I think it's for the system to make those differences less divisive. So for a person to be, it was a nurse who'd been a nurse for a very long time that said to me, and she was very upset, that essentially when people were admitted to her ward, they would be catheterised rather than taken to the toilet if they were frail, because essentially it wasn't a medical issue going to the toilet, and therefore that seemed like a medically appropriate thing. I think there are people across all these professions crying out to see that those changes are come about, and I think that the idea that we divide more what is care and what is healthcare is a road which I think we've gone down too far already, and we need to pull it back. And so I think a greater recognition that for the public, the difference between what care is and what medical care is. Let's take district nurses. We now have significantly less district nurses than we had a decade ago. We have more nurses in hospital, but we have less district nurses. That is telling us something about, I think, the withdrawal of what the public would not, I don't know, the difference between one osteopath and another osteopath, one physio and another physio, one nurse that's called district and one care worker that's got, that is actually taking my blood pressure and possibly taking my bloods. I think we keep imposing on the public, and we're still doing it now, that they have to understand our system. We need to understand them and what's happening in their lives, really.
People will delve down a lot deeper, but I'm going to hand back to the chair. I think that's
Very
a good
much.
place
That
to
was
start.
deep enough for me.
Pretty deep. Josh Fenton-Glynn.
Thank you, Baroness Casey. You talked about quite a lot about the need for a national conversation. Can I go to a very specific conversation? Cross-party talks, how are they going?
So, I knew you'd ask me about cross-party talks. So essentially, look, cross-party talks are going to be difficult. So they're going well at the moment. I would say everybody agrees on the diagnosis of the problem. The trick is going to be shifting from that to agreeing on what the solution is. And so that's partly our job, is to try not only to lay bare what the evidence is, but to find solutions that can gain cross-party consensus. And that's where the dialogue with the public is going to be so important and powerful, because then we can reflect that back to colleagues in the cross-party talks. But to be fair, and I must be absolutely clear, I would say we have had really good discussions. They're not short discussions. We've had really good discussions at both of them. We've had really strong attendance,
I'm
confident.
You said both of them. Does that mean that there have been only 2 sets of cross-party talks?
There's been 2 sets of formal sit-downs of cross-party, and there's been a lot of bilateral conversations that I've done and my team have done directly. So I would imagine...
Bilateral between you and the parties, not between 2 parties?
Correct.
Yeah. Do you think two sets of cross-party talks is enough, so 2 meetings is enough?
So I think yes, or else I'd have had more. I think the issue is that actually what you do behind the scenes is often as important as what you do in front. And I think a lot of the conversations behind the scenes are as important as when we all sit down together. And I think that we will be having another one early autumn, probably around September time, when we're getting stuck into the big conversation, and that will be the right time. And then I think, depending on what happens in the future, and politics is always having been something that's worked in and around it and for it for a long time, you will understand that we just need to weather the vein of what happens in the next few months as well.
Talking about the national conversation, you yourself talked about how many organisations are involved, so 6,200 GP practices, 700 hospitals, 200 NHS trusts, 42 integrated care boards, 317 councils, 153 unitary authorities, 164 district councils, 18,000 providers, and CQC. Are all the different bits of the system talking to each other? I suspect I know the answer.
Do you think they're talking to each other?
Of course not.
When they come before you, do you think you get a sense that they're all talking to each other? The answer to that is definitely no. And it's partly why I said right at the beginning what I think about the sort of the changes, the almost symbolic, let alone real, changes about structure of governance to the integrated care boards, that it's almost at the point that we're saying we should be thinking about neighbourhood health and a left shift. The very people that you're neighbourhood healthing, which is called place nowadays, everybody has to call something place, it's actually, an area, it's, North Allerton, if you see what I mean, or Islington, they're actual places with names, and places with names are run by local authorities. And I think, probably I'm on record over the years as being somebody, as a public servant, that ideally coterminosity around geographical locations would make life a lot easier for those of us running public services, and it would make collaboration easier as well.
As a former cabinet member for social care, I know very well that integration between health and care. So one of the constraints that you're operating under is that phase one must sit within existing spending plans. How transformative do you think they can be within existing spending plans?
So I don't see it as a constraint. I think that there's something incredibly important about taxpayers are already paying quite a lot of money. Certainly most people pay taxes all their lives. They're paying 41% average council tax towards adult social care, and then when they hit the point that they're older or they need help, we generally make them pay towards their own care. So I think in that scenario, I think we should be looking at, rather than, I think what you could get every stakeholder to agree to is that there is a need for more money. And, it's that classic, if I was looking at homelessness, if I was looking at, lots of things, you can probably get people to agree on one thing, which is more money is needed. I think that we ought to be, and I am, looking at what could be done within the existing resources, where some of my frustrations that are probably already apparent to you are able to say, what could we do better within the existing resources, where I think there are things that could be done within the existing resources.
Okay, so what?
Well, that will be the subject of the report later this year, but to give you a direction of travel, I think multiple assessments on multiple periods, over multiple periods of time, to the degree that people now say, I need a navigator to work out, literally people applying for funding to employ navigators. When in God's name did we think that it was okay that we made our public services fully funded by the taxpayer primarily so blinking complicated that actually I've got charities going out and raising money for navigators? Yeah. So it's incumbent on the people running those services to think about how you do that more straightforwardly. And so I think you have a lot of assessors doing assessing from different places, and then let's move into it. So I'm slightly obsessed, partly because I'm getting old, and I hit 60 last year, and I have been through elderly. I know it's shock, isn't it? It's a lot of money spent on hair. That essentially, and I have domestically social care situations to sort of worry about. That essentially, I think what's really interesting is that we have to work out how we do a better job for people in terms of at least them knowing what's going to happen. So, your man that we met in Newcastle in the carers centre, whose wife had been diagnosed with dementia, was given 2 leaflets, one for personal independence payments, which he did not need and would never have qualified for, and 2, how to pay less council tax, which he did not need and didn't want. Yet we couldn't tell him simply and straightforwardly what the diagnosis meant. Was there any treatment? Because remember, they're in a hospital environment thinking somebody's going to treat me for something, and they didn't, and what was going to happen next. That we can solve.
Just to pull you off the tangent, just talking about how we can deliver things within the same umbrella. I guess one thing that feels quite obvious to me is I look at my local hospital, about 20% of the beds that are taken up there are taken up by people who should be in care settings. Do you think there needs to be more of a free flow of resource between social care and the NHS?
I think that's something, I think you're on the money there, both figuratively and in terms of other ways. I think that So we have seen where there is one employer for something like reablement, where essentially that the local authority have put their reablement people in lock, stock and barrel with the NHS bit in one health trust of reablement, so stepping people out of hospital into somewhere else. And there aren't many examples of that, but we have seen some. And I think that immediately gets rid of this divide and means that you're doing one assessment and you're doing one deal with the public. And at face value, it looks like it's cheaper, or certainly spends less money. But the other way, it's also better for the public, which I think is the thing I'm rather obsessed with.
I mean, good social care is the shift to prevention that we keep hearing about. And with that, I'll have back to the
Ben
chair.
Coleman.
Very quickly, yes, about the conversations you've had, Louise. I just wonder if you've spoken to Hammersmith and Fulham Council, which is the only place in the country in England which is providing home care for free, and tells me that as a result they've seen a reduction in entries to care homes, which of course are different things. Seeing as they're the only people who've been doing it for several years, since 2015 for free, have you talked to them or do you intend to?
Well, I think we have talked to them. Sarah?
As a team. I think there's absolutely a lot that we can learn, and of course, as with Hammersmith and Fulham, there are places across the country. We know it's not all in crisis, and that there are good efforts, there are good initiatives, there are good steps that are being taken to try and make care more accessible for people. I think what we've found, though, is that too often that feels like it's despite the system and led by particular individuals, and in the case of Hammersmith and Fulham, the local population campaigning for change. I think we want to look at what you need across the whole system. What do you need nationally to improve?
I meant that simply in terms of the financing of it, whether it works to make it free because you save money elsewhere.
So I think both in Hammersmith and Fulham, and if you look at Scotland, I would say that it isn't evidenced that it necessarily gets you less money spent on social care. It may stop people going into care homes, possibly, but does that mean that that's a good thing or a bad thing? And are people withdrawing? So we think it's more complicated, and I think it's one of the things that we are looking at.
We're looking at that.
Definitely. Because I think let me just say it out loud, the sort of, when people say things like, let's have a national care service, are they saying that we're suddenly going to find the money from everybody in some way, shape or form, that there will be a totally free kind of care service available for people? And then when you look at the places that say they're doing that, it's not all free, if you see what I mean. So I think it's
all free in Hammersmith and Fulham.
Some of it is all free in Hammersmith and Fulham.
Home care is free.
Home care is free, but
said.
not when you need other care, such as going into a care home.
That's a different thing.
It's a different thing. So I think it might help look at one aspect of it, is all I'm saying. What we're trying to do, and what we will do, is take those. I'm not conscious of where you represent, and good for you. We're not saying that isn't something that we're looking at, but what I said at the very beginning is, and as Sarah's attempted to say, I think that we're saying, is that we want to look at everything and see how everything pieces together and what differences, new aspects would be. My worry is, and why I think we ought to just keep to looking at what the public would see as social care look like if they looked up in 2050, not what will make something easier necessarily now. We have to do both. So we've got to do some stuff that we get on with now, and we've got to do, I think, quite a significant reform of what health and social care looks like.
Come back to that. Joe Robertson, please.
Thank you very much. I'd like to take you to a conversation about dementia, if I may, and particularly the modern service framework that's in development. I share the concerns of some of the leading charities that the ambition may not be realised in the MSF, and the bold transformative change we need may not be realised. Can I ask you to comment on that generally, but more specifically also, should there be an ambition to reduce deaths from dementia, as with cancer and heart disease and others of the biggest killers in this country?
Well, I mean, it was one of the... I mean, it's something I can't convey to you how strongly I think that this policy area needs to be looked at, driven and pushed. That I think it's like an elephant in the room. It's the biggest killer. It's the thing the public worry about the most. And I think it's a very underdeveloped area of policy, basically, both within the Department of Health and more generally. We did a big push on this in the Nuffield speech in March. I think that I wrote at that point and asked that we would kind of up the action on both the trials around dementia, the sort of scientific approach, that we would consider it alongside of what we're trying to do on other diseases and conditions. I have been very struck by, I think, David Cameron had a push on dementia, and I sort of feel it's gone quite quiet ever since. So that isn't just now. I think it's gone quite quiet in policy terms ever since. I have asked for, and it's been agreed, that we will have a dementia czar. I know that's old school. Forgive me, I've been a czar in my time. And sometimes what you need is somebody that's just utterly dedicated and has the credibility to work across the system and be heard. So it's not, it's somebody that would come before this sort of select committee and account for the work. It's somebody that will have be accountable to ministers, but somebody that actually has to drive the whole dementia work forward. And I'm pushing very hard for that, and that has been agreed by ministers that will happen.
So having won the argument on the dementia czar, how quickly would you like to see that role appointed to?
Well, I would say, and I don't think the chair will mind me saying this, that in the scheme of government moving in recent times, I would say that to have asked for that in March and for it to have been agreed and underway by now is quite quick. And so I take that and think, thank you, basically, and they will recruit, and they have told us that that will happen very, very soon. So, and of course, I will be watching and helping to make sure that that lands in the right place.
Can I just ask you something on diagnosis targets as well for dementia? I mean, I was critical that it came out of the NHS planning guidance, but putting that to one side, and I take the government's wider point that driving things with endless targets doesn't necessarily lead to better outcomes. However, clearly accurate diagnosis of dementia is going to be key, particularly down the track as we get the potential for treatments. Can you say anything about embedding diagnosis targets for accurate diagnosis within dementia, whether that be in the modern service framework or the NHS planning guidance or elsewhere? Can you explain, as you see it, the role for that and how important it is?
So, I mean, I would not at this stage feel sufficiently qualified to take a view on what targets should be put in what places, and maybe that's a failing on my part, but I can't sit before you now and say I think that target should be here and that target shouldn't, because I think there are often unintended consequences of targets and they need to be thought about quite carefully. What I do think is that the area that we're talking about, and social care more generally, there appears to be no targets, either for assessment times. I mean, let's take motor neurone disease, which is another bugbear of mine, that it just seems to me that we have targets in some area of business in the NHS, but no targets elsewhere. And I think that's because this area of the elderly and dementia is unloved and doesn't have the same status as other areas, both in medicine and more generally. And I think that the power of the voice of the elderly is often over. People think that they're incredibly powerful. Well, where I'm looking at it, I think that they're unheard and they're unseen. And probably now there are people living in the weather that we're in right now where they're even less unseen. Do you know what I mean? I just cannot bear how we seem to have neglected the area of the elderly and how we treat them in society and how we look after them, and the responsibility. We're all born, and once you're born, you're all going to die. It's, as the sun comes up and goes down, that's going to happen. And why, therefore, we can't think about that in terms of how we organise ourselves in public policy, I don't know. And I also don't know how the most amazing thing has happened, which is life expectancy has doubled in a century, but we've stuck our heads in the sand about what that means. And we can't continue to stick our heads in the sand about it, because there'll be people on wards right now that are so hot, so unhydrated, and will anybody be taking the water to make sure they stay alive today? That's how bad I think it is, and that's how unloved this particular area of policy is.
But on the matter of targets, I mean, the waiting time for dementia diagnosis and then diagnosis to referral are far too long, and all the other big killers, of course dementia being the biggest, have far better waiting times, although not as short as they perhaps should be. Unless there's a target or some very specific ambition, I worry that it will continue to be the poorer, unloved issue that it shouldn't be.
Yes, I think that's fair in terms of the modern service framework has to be a lot more than using words like pathways. I kind of dread the word pathway, partly because I don't want to look down what that pathway is going to be. It's like when somebody says to me, there's a social care front door, I hope it's the front door we never have to go through. I think that we've got to be much clearer about those sorts of issues, i.e. once you're diagnosed, that man in Newcastle should know, if the modern service framework stands up to scrutiny, that the sorts of things you have just talked about, they will know where they stand with them. And I would like a time where actually there are treatment options, and that the same way we drive treatment options for other major diseases, I would like us to think about how we do that as well. And I'm really pleased that in my ask for that in March, I have been reassured by ministers that they are with us on that in terms of trying to up the level of trials and motor that much more.
Can I just finish by going back to an earlier exchange you had with my colleague around removing local authority representation from integrated care boards? That seems to me the very opposite of integration, right, at a time where we need more. Can you say something a little bit more about that, and either whether you would disagree that it should happen at all, or if you see it as inevitable, what is the way of getting around the issue of less joined up working when we need more of it, particularly for social care?
Well, I mean, I think it's probably, I used to have a boss, Sheila McKechnie, that used to say it's left hand, right hand. And for years I had no idea what she meant, and now I know what she means. That essentially the left hand is doing one thing and the right hand is doing another thing, but it's the same body doing it. And having, I was thinking, how long have I, from Rough Sleepers onwards, which was 1998, 1999, I've been around a long time. And I think that sometimes the system doesn't knowingly know what it is always doing. And I am hoping this fits into the not knowingly know what it is doing. So as they're restructuring integrated care boards into much bigger things because they need to and they want to, at the same time then what happens is something drops off that actually is quite significant. Now, I would have argued, if you'd had me here before those changes were proposed, that actually local authorities were already the minnow in the sea, quite often, of sharks in this scenario, and that essentially they have no equal voice. And I think if you think of where people live and what people think, they often think their local council is kind of theirs, if you see what I mean. And I believe 4 years, if this was the Home Affairs Select Committee, you would have had me saying 4 years that coterminosity between public services would mean something to the public, and it would make running those public services more straightforward. It would be the same in crime as it would be in health. And I think what you've got is over here, you've got the police service potentially restructuring. Sorry, I know this isn't mission critical, but it's these two big giants. You've got the health, which is a giant, and then you've got something like the cops that are giants. They're politically sensitive and they're higher profile than what you can do around local government. So I think that my worry, my continuation of the worry, is that local government is not just a key partner that you can decide whether they're going to be one of 15 on your board in the world of health, They're the people that a colleague over there talked about. Like, there are 20 people on a ward that can't be discharged. So whose problem is that then? That's now seen as the local authority's failure. Not that we haven't brigaded ourselves, organised ourselves and sorted out ourselves so that actually that's all of our problem. It's like the acute trusts run the show and local authorities are bit parts in whether they get the crumbs that fall from the table. And until that psychologically changes and they're seen as equal partners, then I can't see how you reform all of this, including social care.
I will disagree with you and say that is mission critical. Thank you very much for you saying that. Dr. Becky Cooper, please.
Yeah, thanks, Chair. I think you've answered my question, really, but I'll just see if we can dig a bit deeper. So the relationship between the healthcare service and social care, what do you think are the main reasons? Give me one, give me two. You've given me the sort of the disparity between, the power disparity. Why don't health and social care work better together? Because it's clearly a no-brainer, right? In your experience, your vast experience, why don't they work better together?
So you can't do a left shift unless you've met your elective waiting time targets. Completely understand that. I understand why, if you're in central government and you're trying to get waiting lists down, you don't let anybody do anything other than waiting lists. To quote a colleague, you've got people being waterboarded in the back of some room so that they meet their waiting lists, whilst you've got me saying, what are you doing about the left shift into neighbourhoods? I mean, that is the reality of politics, it's the reality of government, it's the reality of local government, it's the reality of life. And so occasionally what you do is you ask somebody, like me and others, to say, how do you find a way through it? So neither of those people are bad people. The people trying to get waiting lists down are good people trying to do the right thing, because there's loads of people that want the waiting list down. And the people trying to do the left shift are also good people. But actually, what I would say is that over time, you want to be able to do both. So I'm not sure that people set out to not get it right. We've seen enormous numbers of places where good practice gets you closer. But I would say quite often that good practice gets you to the co-location of teams in the same porter cabin, which is slightly different to those three teams doing one thing together, rather than one bit of the hospital doing one set of assessments for step down or discharge, another bit of the system chasing people out of the hospital as quickly as possible, God love them, what a job, in order to let people come through, and a third bit of the system being the local authority social care, which has its own rules, its own data sets and its own way of doing assessments. Sure. The good practice there is they're all in the same place and they're able to talk about the same patients and then members of the public in the same way.
I hear you. So reflecting back what you've said, basically, the deep and fundamental divide, I'm reflecting back what you said, really is around central government direction on where you put your money and where you put your emphasis and where you put your resources. And that at the moment is get your waiting list down, and it's very difficult to look at other things in the system while that's the emphasis. Is that a fair reflection?
I would say that the domination of the acute trusts and what it is they're trying to deal with, and remember, I don't want them not to exist.
We all need them when we get sick, yes.
I'm a member of the public, and therefore I'm very, very clear about the NHS. I'm very clear on how beloved it is and how needed it is, and how it actually has stood the test of time of something that we think will always be there. So I don't want to be overly negative.
I understand. We're all going to need we all will need the acute trust if we're sick. We don't want a public health doctor if we're having a heart attack. So, but in order to get to where we want to go, which I think is we want the NHS and social care to work together as we need them to work together, how do we fix that fundamental problem that you've just identified? Is it funding flows?
I think it will be a mixture of things, I think. And really this is the big question, one of the big questions that we are responsible for answering, and I'm probably not ready to completely give you the answer to that now. But I think the direction of travel for me definitely takes us to the route of kind of making it simpler for the public, things like multiple assessments. I think things like making it clearer to the public what is going on in their lives and what the difference is. I think that I'm very clear that, and colleagues in the Department of Health know this, that I am pushing very hard on neighbourhood health. I'm using the language of the NHS 10-year plan. I'm very keen that we look at what is a left shift and how social care is integrated into that in a different way. The other thing I just want to say, in answer to your first question, is when NHS colleagues talk about integration, they're largely talking about integrating themselves. It's not local authorities they're integrating with. It's really interesting when you say, you go along, you get the presentation, whether it's an integrated care, it's just very interesting. And also they use the word care. So a lot of healthcare uses the word care, but that isn't the care that allows me to get help to be fed so I don't choke, or it isn't the help that allows me to be showered or taken to the loo. Oh. And so I think that that's partly why we think that we need to reset the conversation with the public about what care and health is, because I think that and it's something, hope, Paulette, you don't mind me using your first name, but what you said about your 25 years as a nurse, I think you spoke for, the way you described it, a lot of people in the professions and a lot of the public who don't see the differences between these things and just want somebody to help them.
And I think that's a really good point. The fact that healthcare stands on its own as a system, beloved, as you say, and social care does not stand on its own as a system. It's integrated into arguably a very strange world, which doesn't really look like a social care world. Local authority looks like emptying bins and sorting out all sorts of problems. Social care is a very distinct problem from from the vast majority of other local authority issues. Is it therefore reasonable to say that social care, and there were reasons why social care was put into local authorities, is it fair to say that actually social care sitting in local authorities is part of the problem here, because social care is a different beast to local authorities?
Social care, that's so interesting. Maybe I'm just too old. I remember when social services in local government, when the history of it, when it was switched, basically local authorities are the public. They are closer to the public than any other institution. Councillors are the public represented, and they stand in a very different role. And I think it's become much harder for colleagues in local government, and I'm one of their worst critics and biggest allies, don't get me wrong, but I think that we ought to be a little careful of saying that health would do it any better.
Well, so I'm not saying it would do it any better, Baroness Casey. All I'm saying is that it has autonomy, and it has, you were talking about parity of esteem between health and social care, and we all know that local authorities, unfortunately, are get kicked whenever anything goes wrong. Social care is incredibly important. It does need to have good, close relationships with health. Is that feasible, realistic, if social care remains in that local authority setting?
Yes, I think it is.
Okay.
I definitely think it is. And I also think that one ought to look at the voice of primary care as part of that. So I also think if you look at kind of what's happening around GPs, what's happening around neighbourhoods, what's happening around community health, I think that you would probably, if you were to ask them, they might also make the argument that they don't have parity with acute trusts as well. So I think the closer you get to the public and away from big buildings, essentially, I think that you're asking where I completely think I totally understand, and I think is when what local authorities then have to deal with when it comes particularly to adult, not children. So children's social care, remember, is fully funded and fully organised. Then what adult social care has to do is enter into this world of a huge financial assessment. So this idea of assessment is twofold for local authorities. One is they have to look at how much money we have, what our banks are doing, verifying it. It's a huge process. I'm not saying it's wrong, I'm just saying we forget to talk about that bit. And they have to do these assessments. And I suppose I feel parity is often about culture and about respect, and I think just a nudge in that direction is what I'm trying to do. I think colleagues in the NHS probably think it's a shove, but I'm attempting a nudge.
That's interesting. Thank you.
Thank you very much. Andrew George.
Thank you very much. There doesn't appear to be any ambiguity or ambivalence in your answers so far. So why can't you produce a report now?
Two reasons. The first reason is because I feel a lot of people have done reports quicker and failed. And I think that we ought to be able to brigade the evidence and the solutions in a really substantive and proper way.
2028?
It's by
2028. Oh, right. So
there's somebody sat behind me that very, very carefully put the word by in.
By. Okay, that's helpful. So you're anticipating it coming sooner?
We're joking aside. We need some time, in particular, to do a really deep dive and conversation with the British public. I think if you look at the 21 reviews since 1997 and their predecessors, there's something that was missing, which is kind of, and it is on, what do you think social care is, but also what do you think you should be doing? And what does that look like? It's not just money, it's also kind of what do we expect a citizen or a member of the public to be doing when a lot of my age, my parents didn't live, I didn't have to look after my own parents for a very, very long, protracted period of time, but I have almost family where we are looking after those parents for a very, very protracted period of time. The world has changed, and I think we need to have that dialogue with the public. And I intend to do that and do that really thoroughly and well. The other thing is that, as you have probably gathered, some of the questions that we're grappling with are big. And I think that I'm worried about going too soon on making, let's face it, everybody always likes a bit of a restructure. Yep. Everybody, like ministers arrive and prime ministers arrived, and often the first thing they do is machinery of government changes. I would caution always being like restructuring and restructuring for the sake of restructuring. So I don't want to get it wrong, and I think it's incumbent on us to try and get it as right as we possibly can.
One area which you acknowledge is wrong is the workforce in terms of the paying conditions and the balance and the support. My colleague Danny Beals will come in and talk about, rather ask about visas in a moment, but certainly the balance between kind of home produced care workers and recruitment overseas. I mean, what do you see as being the main fault lines in there if we're to have a workforce that is capable, competent and secure enough to be able to provide for the future, particularly if you're looking at sort of decades ahead to ensure that we have a resilient service?
So if I just, apart from your next person giving evidence is the minister responsible for that area of work and actually has made huge strides in it. Yes. So rather for Minister Kinnock to answer that than me. But I did feel some relief to know that there is a fair pay agreement. There is £500 million allocated to it, and that change will come during the time that we're doing this review, because it feels like it's one of the things that needs to be got on with, and I think the government are getting on with it. So good, I've boxed that off as something.
But let me just interrupt. I mean, £500 million will deliver a 20p in the hour, pay rise.
There are larger. So what we're trying to do, I think, in the Social Care Commission is look at what the overall system, if there is going to be one system, looks like. I think within that, my starting point would be It's a bit like when we did troubled families and before that family intervention under the work that programme, both under the Conservatives and a version of it under Labour, that the starting point, and I regret not doing it now, is that we had people called family intervention workers that weren't quite social workers, but they had no professional qualification, there was no register of them, there was no training of them. One of the first starting points you could do would be to essentially try and carve out an actual profession that we used some of that money to try and actually put them on the path of status, moving in the right direction. So I still think there are things that could be done that don't have to wait for big changes.
I mean, it's not just pay, of course. I mean, a lot of the domiciliary services obviously require, paid travel time, paid travel, making sure that the care is provided in sufficient quantity, and they aren't rushed through that. They're able to park somewhere nearby to take equipment, etc. I mean, presumably you're going to be looking at all of that, making recommendations. So, in terms of both pay and the conditions in which they're operating.
Well, I think that the government are already looking at that area of work and are already making changes.
You're satisfied, yeah.
And so we will look at double check along the way. But so far, to be fair to them, they are the first administration in a long time to try and look at those sorts of issues and to do something about it. So the fact that 0-hour contracts will go out the window for care workers is a first, and I'm very grateful for that on behalf of anybody that's had to have care workers come into their home. So I suppose what I'm not trying to avoid your question. No. I'm just trying to say I think the government has a work programme. They need to get on with that work programme. We're running in parallel trying to figure out what reform should look like. And what we have never wanted, and we agreed it with the previous Secretary of State, with the Minister of State and with the new Secretary of State, that they carry on with their work according to the manifesto and all of the commitments that they've laid out. We run in parallel trying to figure out some of the difficult questions, and we collaborate.
Okay. I mean, just moving on to unpaid carers. I mean, you've highlighted the burden that is certainly growing. Largely, I think you're suggesting because social care just isn't able to perform. And I mean, what is your latest assessment in terms of what is required in order to provide carers, family and other carers, sufficient backing so that part of the social care economy just doesn't simply fall over?
So I think that it's a really conscious of time, but
yes,
so I think what's very interesting about the history of what we call social care is that we, all of us collectively, previous governments, have had a go at doing certain things to alleviate specific problems along the way. And kind of unpaid carers and is a good thing to do. And there are other areas that we've talked about today that I would put in that same category. It's not like everything is terrible and nothing is working. There are some things that are okay and some things that are working. They may not just be good enough. I think must make sure I say that. There are countless colleagues and volunteers all around the country doing unbelievable work every single day, and think, what on earth is Louise on about? Calm it, Casey. So I just want to be clear about that. On unpaid carers, I think it's really interesting that it goes into the stock take. That I think that when we look at everybody on the whole, none of us want to be a burden, and we also want to look after people, and we want to look after our family and our friends, and some of us strangers. That is humanity. I think that over a period of time, a whole thing has happened. People have lived for longer, which means that's a trickier level of care to provide. I think we've seen a withdrawal of what we would have thought is care services from those families and those communities. We have done some propping up with good things like carers allowances and things like that, though I have to say almost godson of mine works in a CAB as a leading advisor, and he says of all the people who walk through the door, when somebody says I need help with carers allowances, it's the one that they all back off and think, God, we must get, he's called Little John, he's huge, he's about 6 foot tall, we must get John to do it because he's the only one that can do it. So these are good things, but we could make them easier. And my cry really on behalf of carers is actually they need things like definite respite. You know, there are some things, just practical things, that seem impossible, and I think that we could be better at that within the existing resources.
Very much.
Thank you, Danny Bills.
Thank you. Morning, Baroness Casey. I've had the pleasure of visiting a number of care providers in my constituency in recent months, and I must say visa changes is an issue they bring up first and foremost with me. You've held a lot of conversations and engagement. What feedback have you heard about concerns about changing migration rules and the impact on the quality of care and staffing? In particular, what's been raised with me is staff come over on visas, they're trained up after a number of years, they become expert, and then they're not able to be kept beyond a handful of years, and they kind of leave service. It feels like a kind of brain drain away from social care. So what have you heard? What views do you have about the kind of visa system? And would you support a kind of visa for the whole social care system rather than one linked to employers, which can also be open to abuse?
So first of all, I think it's a problem that is inherited as a sort of busted system or no system of social care. So, you know, it's a specific symptom of something much bigger, which actually your colleague asked about earlier, which is, you know, what is our approach to care workers? How should they be paid? Are they on 0-hour contracts? Are they paid to move between places? It's part of a much wider issue of care workers. We have picked up in some areas that people are concerned about visa changes. I would also say, sorry to be utterly blunt, I've also picked up that it's obviously people are unhappy with those visa changes that will then say there's a problem with those visa changes. So I just have to be really open about this, which is I think people who don't like the visa changes will say this is an issue, and there are other genuine areas where actually you're looking at care homes where visa changes may make this really difficult, or domiciliary care. And my job in the middle of this is to be as pragmatic and sensible about the way forward. But to say, I think sometimes politics gets in the way.
Do you have any emerging views in your initial report about this area? Should they align with health visas and the approach in healthcare?
No, because I have other views about what I think we should do in terms of visas, and but that's my personal opinion. What I have to do in this job is manage what is there ahead of us and try and make the best sense of it. Do I think we should have people that want to be care workers who are 16, 17 and 18, this vision of people that say if somebody's a care worker at 17, she should be able to be, it's always a she should be able to be, why isn't it a he? But anyway, I'll come back to that another day. Why aren't they able to be the chief nurse of the local hospital? We are so far away from that being a reality. I'd rather we started there and think, so how would you create a sense that this is a really decent job for people to do, that they gain skills, they have qualifications, they're registered, they're DBS checked, that it's an honour to look after somebody who is either disabled or frail. It's an honour. I work directly with people when I was homeless. The honour that those people have who are caring is not able to be continued. They're not able to continue to care because of the structure of the visa system, and they want to, and they're expert after 3, 4, 5 years, but they're not able to stay in the care system and they leave. So is that not a problem? As you know, that is right now a question that is above my pay grade, and I do not intend to get drawn into it.
Will your initial report say anything about the changes that are happening and the impacts on the service now?
We will assess as we move into our autumn and winter report whether there are legs in that or not.
Thank you.
Thank you. So can I ask, come back to a couple of things that you might have discussed, particularly around local authorities. Have you, as you know, there is unitarisation going on, there is foundation, strategic authorities being pulled together, there's a lot going on in the local authority space at the same time as a reorganisation in the NHS. And meanwhile, this commission is doing its work, but at the moment you are the submarine, and at some point you will fully emerge, and we're excited for it. As you know, this committee has been pushing on this from day one. And I share your concern about left hand, right hand, but in fact there's 3 hands here because you're the third. Can you comment, if you can, on the ability for government to understand how this needs to join up, and what effect the changes in the local government bill that's being put forward might have on this? What are the risks and what are the opportunities that you see?
So I think that, as I said earlier, I'm a great believer in kind of named places. I'm not somebody that likes the word place very much, but I like the name of who I pay my council tax to. And I can associate myself with that. And I think if you ask the public that, they probably say the same thing. I think that there are changes, I have for a while, and if you look at social care, the fact that an individual or family has to deal with the district council when it comes to housing, has to deal with the county council when it comes to social care, and then health is somewhere else. I think that's quite complicated, and I would really have liked, and still would like at some point, when the reckoning happens, that we are much better at coterminosity. That's not happening, is it? I mean, in my own area, the health board is not going to be coterminous with any of the larger authorities. Some of the local government reorganisation will be better for social care. So the fact that housing will be part of bringing housing into social care, or social care into housing, I can only see as a good thing. I can't see that that's a bad thing. I think that there are changes like that in local government reorganisation that will be really, really powerful and good. And I was up in North Yorkshire, we were there, and they went early with unitary. They've got it right, as far as they believe they have, and nothing I could see that would make me disagree with that. And I was very struck by how they've reorganised adult social care across North Yorkshire, with all of the districts integrated. And I know it's still early days, they're only a couple of years into it, but it really gives me hope that that could be a really good way of kind of playing to the best of local government reorganisation. I suppose what I'm trying to get to is just there's a lot of uncertainty in the NHS, there's a lot of uncertainty going on in local authorities. Are you seeing any of that play out in social care as you go around the country? I think we're always used to uncertainty. I'd say the NHS is one of the most sort of restructured entities, but it carries on. It pretty much carries on in the way that it's always carried on. And I would say local authorities, at the end of the day, they are elected by the people they're elected, and they will carry on. And I think that connection with the public, particularly for colleagues in local government, will remain incredibly powerful. As you know, the vision for how this is going to work from government is that health and wellbeing boards are going to suddenly have this power to bring everyone together. Do you have faith that that will work? I think that it's one of the things we're going to look at carefully. I'm not really wanting to make restructuring recommendations, if I'm honest. And that's the plan. That's in the bill. But that's in the bill. I don't particularly want to come across that in a year's time and say, oh, that's all wrong. Do you know what I mean? That would just be That's sort of my point. False. I mean, if we've got a chance to warn them that this isn't the right path to go down, for example, we have an amendment down to the bill saying do not remove local authorities from ICB boards, because we think that is a strategic mistake, knowing where you're headed. And it's very helpful that you've clarified where you are headed. Are there other things in the bill that we should be pushing on to say you need to clear the path so that when you report, this isn't an inadvertent thing you've made more difficult? I could probably go away, if that's okay, and double check my homework and come back to you if I think there is something else that would be helpful. I would also do that directly with colleagues in the Department of Health. My thing about the local government one on the ICBs is I feel it's as cultural and symbolic as it is real. because actually you can make health and wellbeing boards work. You can get collaboration between colleagues in local government and colleagues in the Department of Health, but it takes a mind shift. So just, I'll leave you with this thought. The world of social prescribing, which has become a thing, and everybody really likes it. I'm sure I like it too, particularly if I'm on the receiving end of it. There's a part of me that looks at that and thinks, is that social care? So there I am, sat next to 2 volunteers in Shrewsbury who are running a loneliness project. Their main referrals now are from social prescribing. Mm-hmm. And they're people that are lonely and have mental health problems and need things to do in the community. That's where they're getting their referrals from. No money, but referrals from. So I think in all of this is something which, if people have a cultural shift, then, and the other thing, just maybe I'm getting old, but the kind of, I thought about it, therefore it's new and therefore it will work, is the path which sometimes we go down, and we ought to check what's happening in the room next door, whether somebody's done it already and whether there's a better way that they do it differently, is all I would say.
Can I link to that is the funding? I mean, again, local authorities are very strapped for cash. They used to commission many of these services. They now can't. GPs are seeing the fallout. They're trying to socially prescribe to things that are increasingly...
Absolutely.
We are in a sort of vicious cycle. And I just wanted to drill down just on the constraints, because this is the constraint you have is within existing spending plans from government, right? But meanwhile, as you yourself have pointed out, there are people who are spending tens, sometimes hundreds of thousands of pounds on their care. And so the overall quantum that is being spent on social care by the public goes far beyond what government is spending on social care because of how much the private sector, as you've said, is involved. So when you're looking at the settlement that you're moving towards, are you just focused on what government is spending, or are you looking overall at how much the individuals of our country are spending on this? And are you going to be coming up with a funding settlement that takes all of that into account?
Well, I think I'll just be careful. I myself will be careful about using the expression coming up with a funding settlement, because we need to have the big conversation with the public about appetites across the board, and that I operate within, it's an independent commission, but it has to work within the current fiscal rules and guidelines, and we need to be careful about over-raising expectations. It have to be very managed. I think the other thing is that when we looked at kind of what evidence is there, what information is there, the bit I found quite interesting is there isn't a lot of information historically that has been gathered about precisely what you've just talked about. So, we're dependent, and by we, I mean the Department of Health as much as the Commission, on, a private organisation called Languissant. I can only remember it because it's got such a nice name, that essentially they're the people that can tell you what's happening in private care homes, not anybody else. Not, so I found the sort of, when you start a review like this and lots of other good people have looked at it before, what you do is you go looking through all of the cupboards to try and work out what they know, how they know it, and why they don't.
And what we know from our cost of inaction report is that actually there's very little out there.
There's very little out there.
Actual evidence. In fact, one of our recommendations for you guys was, can you go get it? Sounds like you're trying your best.
We are, and we are doing, I thought that there would be greater financial modelling about what the population might require and need as time went on. And beyond the world of, we've got people in hospital that we should be discharging and what they cost, and not discharging them what it costs us. I mean, I'm making it sound slightly more extreme than it is, but they didn't feel that there was a lot more, which is another reason why we've had to.
Quite specifically, I just want to understand from my own expectation management what's in scope and what isn't. So, for example, we're looking at, personal accounts that people could build up over time to pay for their social care, or an insurance model, which
everything's in
is
scope.
Everything in scope.
Everything's in scope.
So it's possible you'll look at all of these as solutions.
Everything's in scope yes, and partly that's why the next job is to do this big conversation with the public. Also in scope is finding out what their appetite is for helping themselves.
Understood. And you're having the conversation with the public, you've had the cross-party talks. I want to ask you, you are very good at answering direct questions, and so I'm going to ask you one. Do you genuinely feel that there is political will, not just right now, not just as a sticking plaster, but genuinely in the medium and long term, to solve this problem?
Well, the history shows that when it gets close, the answer to that question is no. And from your death taxes to your dementia taxes and so on and so forth, and it's largely around the money.
Yep.
I would say that there does appear to be this sense, I think, of sometimes what you do is you state the bleeding obvious. And I think that we have got two big things happening. We've got the reckoning around the population, and the fact that I think people now do know that they're looking after or being looked after as they get older, and that doesn't feel good enough. The numbers now of people with dementia, the numbers of people over the age of 65, the length that people are still with us after 85, the fastest growing group, the types of comorbidities and the illnesses they have, I think have just become much more in sharp focus, which I think is very helpful politically. And then the other one that I think is really interesting and challenging is actually what's happening with working age, to use the shorthand, disabled.
Yes.
And that you can see just this exponential growth of people that self-define themselves, 16.8 million of us, now would say we have either a long-term condition or a disability. And that's close to it's between a quarter and a third of the population. And I think when you're dealing with those, I would call them long-term but seismic changes, then I think that's like a mirror that I think by holding it up and then providing, God willing, some solutions to it might make this easier. Do I think it has to be a no-fail operation?
Yeah.
And I think that will be hard to do, but everybody wants to do it, Chair. I don't think that people can't see that this is going to happen. There are just too many people that are too worried about either working age adults that should be working, or people as they get older who today are on one of those wards that I can think about that we were in only a couple of weeks ago having a terrible time. And I think it's time we did something about it.
I think we'll end it there because we do need to talk to the Minister. Thank you so much, Baroness Casey. Thank you, Sarah, for coming as well. Thank you very much. Next panel, please.
I'm interested in what she said about several times about we have to look at what people are prepared to do for themselves.
Very much. Panel 2 coming up. We have the Minister responsible, Stephen Kinnock. Would you mind starting by introducing yourselves and what you do? Can we start with the Minister?
Yes, hello, thank you very much. I'm Stephen Kinnock, I'm the Minister of State for Care.
Lovely.
I'm Emily Roche, I'm the Director for Adult Social Care Workforce and Policy at the Department for Health and Social Care.
Thank you.
And I'm Ben Dyson, and I'm the Director leading on Adult Social Care Strategy, Funding and Integrated Care.
Lovely. Thank you very much. Dr. Becky Cooper, please.
Thank you, Chair. Good morning, everybody. So the National Care Service. We have heard from Baroness Casey this morning around her commission and how that's progressing. Minister, could you give us an update from your perspective around your vision for this service and any further detail that you can provide at this time?
Yes, thank you very much for the opportunity to speak with you today. We are absolutely committed to creating a national care service. It of course needs to be fleshed out and further defined. As things stand, I see it as having three main planks. One is around the quality of care. One is around choice and control, so that the person who is the recipient of care has that sense of choice and control. And the other is about better and joined up services, particularly around integration. So I guess you could summarize it as quality, control and integration. And if we can get to a national care service that is based on those three driving principles, I think we will be in a much better place. Now the question is, the government has not been sitting on its hands and waiting for Baroness Casey to flesh out those three core principles. We've been working very hard by delivering £4.6 billion of additional funding to social care local authorities, 1.6 billion this year, rising to 4.6 by 28-29. We're delivering the fair pay agreement. We've given unpaid carers the biggest increase in carers allowance since the system was created in the 1970s. We're working at pace on the digital social care record. We've got a neighbourhood health strategy, which is about primarily, I would say, about preventing avoidable admissions, getting services far more joined up at a local level upstream. So there is a range of work that's ongoing whilst Baroness Casey is developing that fundamental strategic rethink.
Great, thank you, Minister. That's a good succinct summary to start with, and my colleagues will come in on various parts of that. My question is around integration. And when Baroness Casey was here, we were discussing the issues that we all are aware of around the health service and social care working effectively together. Could you discuss what the government is doing at the moment, notwithstanding the Casey review, to address those issues, those structural divides, and how we're moving forward, particularly in light of perhaps the NHS bill, ICB restructuring, local authority devolution, reorganisation? Perhaps you could talk about the steps that are being made at the moment.
Yes, thank you. And I listened with interest to the discussions about ICBs and the role of local authorities. And I want to say that the guiding principle for everything we do is about integration. It's almost as if you could talk about a fourth shift. In the 10-year plan, we talked about hospital to community, sickness to prevention, analog to digital. I think there's a fourth shift, which is from fragmentation to integration. So let's be absolutely
arguably quite
clear.
Difficult, Minister.
It's difficult to do, and the old saying is, culture eats structure for breakfast. So you can do as much restructuring as you like, but fundamentally we have to change the culture, and the culture is that there's too much dominance by acute trusts. We've got to do the left shift. That means giving local authorities a really strong voice on adult social care. It means giving GPs a strong voice on primary care. Community health providers have to be at the table. That is why we've got our neighbourhood health strategy, and that is going to be driven by the health and wellbeing boards. And I think
understood, Minister. Yeah. I understand. Just coming to that point, because my colleague raised this earlier, one of the sort of, sometimes the devil's in the detail, one of the issues that Baroness Casey did raise is within the NHS bill, our local authority colleagues are now no longer statutory appointees on the Integrated Care Board. Given what you said about the fourth shift integration, do you think that's something that should be reconsidered?
Well, what I would say is what the NHS bill actually does is create much stronger integration between ICBs and strategic local authorities. So there is going to be a very strong role for local authorities, but articulated through strategic local authorities and the mayoralities in particular. That's about scale. It's about then enabling a much larger population oversight through this integration. And that, I think, will be a good thing in terms of providing better strategic commissioning and more joined-up services. But what I would say then, at a more, if you like, operational level, at the coalface, the health and wellbeing boards are responsible for bringing together all the key players. Local authorities are absolutely central to the health and wellbeing boards, and they will be driving forward the integrated neighbourhood teams so that we've got those joined-up integrated services at neighbourhood
Understood,
level.
Minister, understood. So the health and wellbeing boards, they've been pretty patchy. to date in terms of how effective and how much power they've actually had. Arguably, the structure that you're describing is, in effect, social care sitting in the unitary authorities, reporting into health and wellbeing boards, and then health and wellbeing boards having some sort of reporting into integrated care boards, TBD. That feels like we're removing that direct strategic input from the social services themselves. I absolutely appreciate strategic authorities, very welcome, but social services, as I understand it, unless you want to tell me differently, will sit at a unitary authority level.
Well, the ICB, with the local authority voice in terms of the strategic planning as articulated through the NHS bill, will be at strategic local authority level, unity authorities as you describe them. The key point is, how do you get the best possible connection between strategy and delivery? And our view is that you do that with a strategic overview of population size of up to 1.5 million, which is what we're going to do through the giving local authorities that voice on with strategic local authorities. And then we're going to have...
Just to be clear for the people listening, because I think it can get a bit confusing, what we're talking about as a unitary authorities, but then strategic authorities are with a region. So, for example, in my area, we're going to have Sussex strategic authorities and then 4 or 5 unitary authorities. So they are different. A strategic authority is not the same as a unitary authority, which is the unit of delivery where the social care services will sit.
Yes, that's right. So what we are saying is at the strategic authority level, that is where local government will have its voice in terms of the overall planning and strategic development.
Okay, and forgive me, Minister, for social care, how will that work? Because the directors of social care will sit in the unitary authority, the health and wellbeing boards will sit in the unitary authority. So at strategic authority level, where is the social care voice?
Well, that will be through the strategic, through the mayoralty, who will have the overall strategic role of bringing together all of the unitary authorities. And I don't think we're prescriptive about who the mayor should appoint to that planning and strategy process. That's going to be up to her or him.
It feels like there might be some technicalities, which I appreciate, but the strategic authority, just be very clear again, the strategic authority will have a mayor, granted, for the most part, not in all places at the moment, and then there will be a board, which essentially will be the unitary authority leaders and deputy leaders. They will hold the mayoralty to account. That is political leadership, great. But there's a strategic piece here where the directors of social care will sit in the unitary authorities. Are you suggesting that there will be a social care director in the strategic authority?
Yes.
Okay. Thank you for clarifying that. No further questions.
Forgive me, Minister, it seems like your plans are going to make the situation more complicated. You say integration is crucial to delivering better social care, and I agree with you. Yet you're removing local authorities from integrated care boards. So for my area, the Isle of Wight Council will lose its position on the integrated care board, but retain all of its responsibilities it currently has. How can that possibly lead to improvements? In my view, it could end up taking us backwards.
We will have a clear connection between strategy and delivery. If we get the overall strategic work right through the strategic local authorities, and then through the very clear guidance that we've given on neighbourhood health, that the health and wellbeing boards have to have that key role, they have to have the relevant local authority social care leadership involved in those with a strong voice, alongside the other key players in terms of neighbourhood health, you will have then that pivotal link between the strategy at the broader population level and how that filters down through the system. Now, you can argue that there should be a middle piece, which is the ICB and the local authority being on the ICB. I would say that it's probably best to have fewer layers rather than more layers. And so what we're doing here is having that key strategic development role, having then the direct connection through to the health and wellbeing boards, through the local authority role on the health and wellbeing boards.
Thank you. I feel like an organogram would be useful at this stage. Ben Coleman.
Yeah, thank you, Minister, for coming today and your colleagues. I have to say, this is desperate, this little bit. There is absolutely nothing from the department that suggests that they really understand how local authorities work. to take probably both, and this is my own experience of having sat on an integrated care board for 3 years, that the NHS is not interested in how local authorities work. And it makes these large statements that we're going to get strategic authorities to do all this, when you don't have the strategic authorities. Or in London, you have strategic authority has no responsibility for social care at all, no budget for social care. It all sits with the local authorities in London, and there is no response, adequate response that we have received as a committee to the questions we have asked again and again and again about how are you actually going to do this. We're still waiting for a response from Penny Dash when we raised this at our last committee meeting. But if you look at the consistent meetings that we've had where we've raised this, we're not getting any comfort from the Department of Health that you understand local authorities and that this is any more than a paper exercise which will fail. Now, if I can come to London specifically, which is because I'm a member of Parliament for a London constituency, and remember, London is 16% of the population of England. You have a mayor, as I say, who has no powers in the area of social care. There is no structure between the local authorities in London and the mayor to enable him to exert the authority that you're planning, and yet you've come up with this idea. And we have no details of how it's going to work. Equally, you have a government organisation, which is reorganisation, which is taking place, where strategic authorities are due to come into being, but that's going to take years. And the bill comes in much more quickly. So what's going to happen in the interim? We have a system that works, and my contention is, and I noticed that neither of your colleagues today, Ms Roche, Mr Dyson, you can come back with me, have a local authority background, and I don't know how many people in the NHS have it, but my contention is the NHS doesn't get local authorities. It constantly seeks to dictate to them, and this is the latest example of that. Unless we get this right, as Louise Casey was saying, we will not succeed in not just in making social care better, but in a whole other range of areas. Are we going to get real concrete detail of how you plan for this to work, including in London, where there's no structure in place that's suitable for this?
Well, I'll bring Ben and Emily in now. The one thing I would add is that I think it's really important to underline the importance of what we're doing on neighbourhood health. And that is about bottom-up organic change. That is about changing the culture. And there could not have been stronger and clearer guidance, in my view, from the department, on how we're going to design and develop and deliver neighbourhood health. And I co-chair the Neighbourhood Health Oversight Board with Dr. Penny Dash, and I am like a broken record on that board, which is we must ensure that local authorities are front and centre of the way that we do neighbourhood health. And I've been on visits. I went to the Washwood Centre in Birmingham,
terrific. And
it was excellent because it was the local authority played a crucial role in the design and development of adult social care services.
That's terrific, and I think we are absolutely as one on that, and I really respect the work you're doing there. I think it's tremendous. But in London, it doesn't work. The plan that the government's come up with, and I have been talking about this for 2 years now, since one of your colleagues was in front of us in a different... And in London, there is you need to change fundamentally the relationship between the mayor and the local authorities. And if you're going to do it in social care, you're going to want to do it in lots of other areas. And I'm not aware this has been discussed with London leaders. I don't know if it's even discussed with the mayor, but we have no detail of what's going to happen. Something that affects 16% of the population at least. And there are other parts of the country which will have similar concerns. Mr Dyson, I see you're nodding here.
If I may, first off on the question of social care leadership in the department, Emily and I are members of a team that also includes Sarah McClinton, the Chief Social Worker with an extensive experience in local government, and Ian McBeath, who also comes from direct experience of running social services in a local area. So although I don't have personal experience of running social care services, I work very closely with colleagues that do, and we have a very close relationship with directors of adult social services up and down the country. On the question of I won't get into the territory of the debate about who should be represented on strategic on ICBs.
Why would you get into that? Isn't that the fundamental point here?
I don't want to prejudice the parliamentary debate that will clearly take place on
parliamentary debate. You need to spell out what you mean, surely.
What I would say is that the 10-year health plan is predicated on part on the principle that real change happens largely at a place level, as Baroness Casey described earlier. So that the place level is essentially the area represented by the Unitary Authority, by the Health and Wellbeing Board. And I mean, yes, ICBs as strategic commissioners have an important role, but much of the detailed service design and decisions about how you use resources differently, how you partner differently with the social care sector, how you involve unpaid carers and so forth, that happens at a much more local level.
Sorry,
and that is why...
That's not how it worked in my experience. ICBs are going to commission services which local authorities are going to have to provide. Local authorities need much more, I would have thought, representation, not a reduced representation on integrated care boards, to have some sort of parity.
Local authorities are largely responsible for commissioning social care services, with the exception of continuing health care.
A lot of the funding comes through the Better Care Fund, and the budgets don't match, the timings of the budgets don't match for that. Are you looking at how you can, for example, local authority budgets work to one timetable, the Better Care Fund of the NHS works to another, so I'm talking from direct experience here. Are you looking at changing that?
Yes.
You are, so that the budget's timing would coincide?
I completely agree that we need to align planning timetables and planning systems. Better Care Fund, an excellent example of that, completely agree. I would just stress, though, that the majority of social care funding comes through local authorities. ICBs are largely responsible for commissioning healthcare services, and so the Health and Wellbeing Board is the place where ICBs, local authorities, and indeed social care providers and voluntary partners come together to agree what is the way in which we are going to design and deliver better services for people with frailty, for people at end of life, for people...
So it doesn't matter whether you have a strategic authority on the integrated care board or not, because that's irrelevant, because it's all going to be health and wellbeing boards which decide.
I don't think that's quite what I'm saying. I'm saying both are important.
Why is it important to have the strategic authority on an integrated care board if it's all going to happen through health and wellbeing boards?
I'm suggesting that the 10-year health plan is predicated on the principle that much of the detailed service design happens at that place level.
And then the decision
and then...
Well, they make a proposal, health and wellbeing boards make a proposal to the ICB and it takes the decision, or...?
The ICBs are responsible for saying what those local providers should be responsible for. So what are the population health outcomes that a group of neighbourhood health providers is
Who's responsible for the budgets? The Health and Wellbeing Board or the ICB?
The ICB allocates the budget. Lots of the decisions about how the
so
budget
in London
is
you'll
used
have the
will be
Mayor of
made
London.
locally.
In London you'll have the Mayor of London allocating the budget for the 41 local authorities. Is that right?
Local authorities are responsible for how they use the budgets that are allocated to them.
Sorry, I'm going to ask, have you looked, let me ask you a different question, have you looked specifically at London, at the way it's structured at the moment, and have you looked at it? And if you have you thought about how to address the challenge? Have you looked at it, yes or no? It's only a yes or no question.
Yes.
Okay,
yeah.
And so what problems have you identified as a result of looking at London particularly? With the relationship with the mayor, who has no health responsibility except a little bit for public health, and the local authorities who have total social care responsibility.
I think that the challenges we are describing exist both in London and in other areas.
What have you looked at for London? So what have you looked at for London, though? And Becky, so what are you looking at where you're having strategic authorities which are going to be, don't have any responsibility for health, are going to be agreeing the budgets for local authorities who are going to be removed from integrated care boards? Have you recognised that problem, and how are you planning to address it? Are you planning to create structural changes in the relationships?
I have to come back to a policy set out in the 10-year health plan, which the Minister's described, that is predicated on ICBs giving resources to local healthcare providers, government giving resources to local authorities, and then using the health and wellbeing board to bring those people together.
We've all read that. I wasn't asking that question. I very much appreciate you're striving to answer the question as best you can, and thank you for that. But it wasn't. The question is, there are particular challenges that don't seem to be explicitly addressed, which is the fact that you either don't have strategic authorities in place, or you have them in place but they have no health powers, and that's going to very much change the balance with local authorities who aren't aware that they're going to effectively have someone else sitting on the board taking decisions from them who doesn't have formal authority in this area. Have you recognised that, and are you doing anything to try and address that?
I believe, yes, that the government and the department are addressing that.
Can you write to us about how you're specifically addressing that?
Yeah, perfect.
I most appreciate that.
Yeah.
Just one final...
Sorry, I'm so sorry. We really have
done?
to move on.
We're out of
I'm
time.
so sorry. But can I just endorse that line of questioning? Minister, come on. I mean, come on. What was your response to that exchange? Because my colleague is absolutely correct. We are the broken record on this issue over and over again. All we want are some quite basic answers. This shouldn't be rocket science, and yet basic answers, whether it's on the floor of the House, here, we don't get them. So would you undertake to write to us this week, because this should have been already thought through, this isn't new stuff, hopefully, so that we can understand, so that our colleagues on the Bill Committee can relay to the Bill Committee whether or not they should back our amendment that we've put down, that you should not be removing local authorities from boards. Because from where I'm sitting right now, we have yet to hear a cogent argument for why this should happen. Alex McIntyre.
Just say yes, absolutely. I will do that,
I'm
Chair.
assuming yes.
All very clearly noted. Thank you.
Thank you, and thank you for your answer so far, Minister. The Commission's been told to operate within existing financial and fiscal constraints. That's not realistic, is it?
Well, I think there's 2 points there. One is the phase 1 and what we can do before an overall rewiring of the way in which adult social care is funded has been agreed. And that phase 1 recommendations and changes needs to take place within the existing fiscal envelope. And that may well, though, involve some reprioritising of resources, as Baroness Casey was saying. The fiscal envelope for adult social care is going to be the number one challenge that needs to be addressed in phase 2. And that is, of course, where we're seeking to build a national consensus and cross-party consensus so that this issue of how to fund adult social care doesn't become a political football and get weaponised. Our party is just as guilty as doing that as others. And we have to ensure that doesn't happen. So I think there's, just to clarify, when we talk about the fiscal envelope, phase 1 current, phase 2 is about changing the fiscal envelope.
All options on the table for that phase 2 report?
Yes, absolutely. There are many ways of skinning that particular cat.
And do you think, given the emergency that we're currently facing in the social care sector, do you think that the timescales involved with actually dealing with that funding are the right timescales, or should we be accelerating that?
Well, as Baroness Casey made clear, it's by 2028. 2028 is a deadline, not a target. I'm absolutely clear that it needs to be quicker. I will tell you quite clearly that I did not agree with the position that the Chancellor and the Prime Minister took in terms of the time frame that was given to Louise Casey. I think that it needs to be brought forward, and I hope that we can work at pace as and when we have a new Prime Minister to ensure that we've got the Treasury and Number 10 and the Department for Health and Social Care working in lockstep and recognising the urgency of the issue.
Think Labour, I think, have published something today, and the Social Market Foundation earlier this year saying quite clearly that the burden on local authorities to fund large chunks of social care is not sustainable going forward, and it currently accounts for 25% of council tax revenues. Is that something that you think we should be looking at long term to take that out of local authorities and funding this at a national level?
Well, local authorities were hollowed out by 14 years of austerity, and the way in which this issue's been constantly kicked down the road is not acceptable. I think all options should be on the table in terms of how we fund it. We, of course, do have to recognise that the public finances are in a very parlous state. We're currently paying £100 billion a year just to service the interest on our debt. So we do have to recognise that the financial position has to be one that is funded, properly costed, properly funded, and we're not at all writing a blank cheque here. But what I do hope is that we can bring recommendations forward on how to fund this and build that cross-party consensus so that ideally within this Parliament we've got a fully funded and costed model that we can move forward on together in a sustainable way that will transcend the vagaries of the parliamentary cycle.
So, moving on to workforce, the Fair Pay Agreement is not expected until 2028. We've got massive shortages in the meantime. How are the department going to deal with that?
Well, the £500 million for the Fair Pay Agreement is very much a down payment. That is for 1 year, and it's very important that as we move into either a new and reformed way of funding adult social care, or at least into the new spending review process, that we continue to deliver that pay rise for care workers. We currently have 1.6 million care workers in our country. I want to pay tribute to the amazing work that they do. It is quite encouraging to see that the number of vacancies are going down and the number of hires are going up. So it's that's not going as fast as we would like to see, but I think that there are some encouraging signs. But I think we're turning it into a more attractive profession.
Just to put that into the context, Minister, 335,000 people left the sector last year, or left a role in the sector last year, many of whom cited pay and conditions as the main reason for doing so. Given that we have, still a shortage, despite the 1.6 million who are doing a very good job, we have a shortage, we have a lack of people, we have a lack of places. What can we do now to deliver that in advance of further changes down the line? I appreciate, there are cavalry is coming, but what is the department doing today to make sure we can fill some of those vacancies quicker? Not least given, obviously, the comments earlier made about changes to the immigration rules, which a lot of care providers in my constituency are concerned about, will mean that there will be a lot of staff leaving the sector without the replacements there ready to be hired.
Yeah, I think given the fiscal constraints that we just discussed, there's something about making the profession more attractive, valuing it, giving it the esteem that it really deserves. I believe that it should have parity of esteem with the health workforce. And so we are working on things like the care workforce pathway, which is building a sort of career pathway for progression.
When can we expect to see that?
I'll hand over to Emily, who's absolutely our in-house expert on workforce issues, but that is up and running. It's backed by £10 million in 26-27 financial year. We've also got the assessed and supported year in employment. We've got the adult social care learning and development support scheme. So there's
that pathway. Sorry, Emily,
we're doing that pathway work.
In practical terms, for a simple MP like myself, what does that mean this year in my constituency for people working in the care sector in Gloucester?
So the care workforce pathway is already out there, it's being delivered by our delivery partner, Skills for Care, and what it does for the first time ever is set out the kind of set of roles that you can expect to go through in a career in care, from being brand new to care, to being a care worker, to an enhanced care worker that might do more delegated activities through to a manager, etc. And it sets out the kind of development and training that that providers should make sure that people have at those levels. As the Minister said, sort of alongside that, the department provides £10 million of funding for training qualifications that providers can be reimbursed for, including the kind of level 2 care certificate. So it's a first step towards that, what Baroness Casey was saying about having a clear pathway, and sort of paired with the FPA. We'd want to kind of build on that and keep expanding it. In fact, it was expanded to a few extra roles earlier this year.
And in terms of, obviously, we've had the report from someone the department knows well, Alan Milburn, reporting back to Secretary of State and Department for Work and Pensions on the number of people not in employment, education or training. What discussions are the department having to join those work streams together? Because it seems there's a real opportunity here. If we've got a sector with lots of vacancies and a lot of young people who aren't in employment, if we're making the sector more attractive, how do we tackle that group particularly?
Absolutely. I mean, we are in discussion with DWP and the review team about that group. I can't share any more at the moment about kind of where we're getting to, but could come back to you with further details on that.
Do you know when we might have more details on that?
I don't have a date right now, but the discussions are very live at the moment.
Fine, thank you. And in terms of the broader workforce planning across health and care, how important do you think the future of the care workforce is going to be, not least given we're still waiting for the long-term workforce plan, which has kind of been pushed back several times now?
Absolutely vital, and I'm very pleased that adult social care workers are within the scope of the 10-year workforce plan.
Do you know when that's coming?
The summer.
Summer 26?
Definitely.
Summer 26?
It's the civil service summer, which is a particular meteorological...
Well, I'll come back to summer definitions in a moment. So I've got quite a lot of questions to get through, not very much time, because I'm covering for a colleague. So we can move on to carers assessment. 73% of carers have not received a carers assessment. Why do you think they're not receiving those assessments, and what action is being taken to improve the uptake?
This speaks to the fragmentation challenge that we were talking about earlier, and the system is too fragmented. I'm pleased that local authorities are committed to modernising the sort of so-called front door, that sort of first point of contact. So we've launched a discovery and testing programme so to look at how best government can support people in navigating the system. We're testing prototypes in terms of what web content now with people with lived experience, and we'll be coming forward later this year with a proposal to create a much clearer and more accessible and user-friendly front door to the system, where you're not being sent from pillar to post on assessments, you're getting it done in one single point of contact.
Great, thank you. And then final question, or area of questioning for me, is about there's been obviously an important Supreme Court judgment recently about protecting vulnerable people at risk of abuse, and it's overturned the key elements of the deprivation of liberty safeguards framework. How is the government making sure that people who lack capacity continue to have their rights and protections upheld? And importantly, previously the department said that we were to get a consultation on the liberty protection safeguards in the first half of 2026. Now, given we have, I think, by my reckoning, 6 days left of the first half of 2026, are we still expecting that in the next week? And if not, when?
You'll be aware of the Cheshire West ruling, which created a radically different approach to this issue. That got challenged. The Supreme Court has, in essence, overturned Cheshire West. One of the reasons that we haven't done the deprivation of liberty work that you just mentioned is because once that challenge came in on Cheshire West, it didn't really make sense to launch anything until we had clarity on that piece. We do now have that clarity. We, of course, respect the Supreme Court's judgment. Our job now is to put that into practice. We issued guidance to public guidance on the 15th of June, but there's no reason at all why people in the relevant authorities can't start immediately to adapt their systems to the new Supreme Court ruling. I know that it's a controversial issue and there are strongly held feelings on all sides. The point I would make is that the impact of the Cheshire West ruling was to very significantly increase the backlog of cases, because it kind of so lowered the bar in terms of the assessments that needed to be made, led to a lot of very intrusive assessments on people that wouldn't necessarily need that. So what I am optimistic about is that thanks to the Supreme Court ruling, we're going to have a more effective and actually more humane system and get through this backlog, which is a big problem.
I guess very final question from me. Do you think, we've got this work that you've said, the backlog and the impact that's having on extremely vulnerable people. And obviously earlier this year we had absolutely horrendous news from St Andrew's Healthcare in Northampton about the alleged treatment. There's an ongoing case there, so we've got to be a bit careful of vulnerable people in their care. Do you think that the department has got a grip of some of the challenges that are facing vulnerable people in our health and care system?
Well, one of the areas of Baroness Casey's speech in the Nuffield think tank was on safeguarding, and I was really pleased to see that, and I'm really pleased that we have actually acted swiftly. We've now created a national safeguarding board chaired by Sarah McClinton, reporting direct to me. Its first job is going to be to do a review of all of the statutory guidance on safeguarding, because there clearly is room for improvement. So I think I think the answer to your question is we need, of course, from the centre to get much more of a grip on this, and this safeguarding board is going to be playing a key role in that, but we do also need to be driving that culture change through the whole system.
Thank you.
Danny Beals, please.
Thank you very much, Minister. Just to quickly follow up on your point about parity of esteem between the social care and health workforce, would that extend to parity of approach around immigration and visa rules? Obviously, in the present proposals, health workers have one set of proposals about indefinite leave to remain and visas. Social care workforce are on a completely different proposed pathway. Is that parity of esteem?
We hugely value the role that care workers from overseas come to provide such care and compassion, and it is hugely appreciated and valued. It is the government's policy to reduce our over-reliance on overseas labour. We want to have a system which is really attractive to our homegrown talent, and to ensure that we've got adult social care being something that people who are resident in this country really want to do. The other thing I'd say is, of course, we've got until 2028 to do a lot of the redeployment of people who've been displaced, because there are lots and lots of abusive, unscrupulous employers out there. The numbers, we've had 1,550 licence revocations, 35,000 displaced workers, 60,000 affected overall. So our top priority, I think, is to ensure that those people who've been so badly treated by unscrupulous employers who've had their licences revoked are now displaced. We've got until 2028 to redeploy those people in the adult social care sector. I think that's low-hanging fruit that we should take.
I agree with you on that point, Minister. Would a single national care visa help tackle exploitation rather than people's employment and presence in the UK being tied to those unscrupulous employers?
I'm really interested in that proposal. I know it's something that Unison are very keen on. They've done some really interesting work on this, and I absolutely think it's something that we should explore. Obviously, that needs to be done in lockstep with our colleagues in the Home Office.
Thank you. Turning to making some of these changes happen, you've talked before at this committee about the role and importance of modern service frameworks for dementia and frailty, and one for palliative care, which you've talked to us about before. They seem to be doing quite a lot of heavy lifting in terms of delivering the improvements that we're hoping for, that Baroness Casey may be envisaging. How are their development, which we understand is underway, how are they being aligned with Baroness Casey's review and initial findings, and what teeth will they have?
On dementia specifically, we're very keen to move as quickly as possible on Baroness Casey's recommendations on dementia. We want to get up from, I think it's sort of 300 odd people doing these trials up to 2,000. We're waiting for NICE to come back. I think on the 9th of July, NICE are going to be giving their view on the donanemab and lecanemab, and that is something that we want to move forward with as quickly as possible. In terms of the modern service framework, I think that's about having we've done a lot of stakeholder engagement. We had a webinar with 200 key players on that just recently, and we've got to bring forward then a very clear definition of what the outcome needs to be, both in terms of the clinical treatment for dementia, but also the wraparound care that is required, and that's going to be the basis for the modern service framework. We've agreed fully with Baroness Casey's recommendation that modern service framework needs to be published by the end of this calendar year.
And if I may, just on the modern service framework as well as kind of setting out the what of the outcome and then the pillars of how to get there, they will also set out sort of which parts of the system are responsible for each part of delivery and the kind of strategy to support delivery and oversee uptake of those standards as well. So they will go.
They speak to local authorities as well as the NHS.
Certainly the dementia and frailty one, which I'm closest to, is going across social care and health and looking at all of the partners involved in delivery.
Specific requirements and recommendations for action from local authorities.
I can't go as far as to say we're going to have a definite list of actions for local authorities, but we are looking at the full set of partners involved in delivering social care.
They're responsible for social care.
Yes, so I would expect that they probably will be. I just can't tell you right now 100% yes, I have a list yet.
The local authorities engaged in the development, the LGA for instance, they engage in development of the MSF.
We've got a really wide set of stakeholders, and to what Baroness Casey was saying earlier about the kind of medical model and social model, this is one of the places in the Dementia and Frailty MSF where those two are really kind of coming together, and we're debating how the two come together best for people who have these conditions.
In terms of their development, Baroness Casey touched upon this earlier, around some of the specifics, but we've had concerns raised from Alzheimer's Society, Alzheimer's Research UK and Dementia UK about what the content may or may not be of the modern service frameworks. Could you kind of yes or no confirm that kind of 3 key areas are going to be covered or are not going to be covered in the MSF? So one is around times to diagnosis and clear standards and targets. Will that be included in the MSF?
Well, first of all, to say that Alzheimer's Society and the other charities are part of our task and finish group at the MSF.
They're very concerned, and they've written publicly, so
no,
they don't feel they're involved, but not necessarily happy with the involvement.
I'm aware of that, but I am pleased to say that each of the areas that they have written to you on, which I think is around earlier diagnosis, the kind of pathway, and then the push on research, all of those are being covered by the MSF. I'm not going to commit to you today that we're going to go for an 18-week target, and back to what Baroness Casey said, we're looking at a range of outcomes.
My question was, will there be specific targets around times for diagnosis? Not 18 weeks per se, but will there be metrics and clear standards or targets around time of diagnosis?
We are considering them at the moment, yes.
So you're considering it, okay. And on the point about pathways, Baroness Casey touched upon how she was uncomfortable about the word pathway. Will there be specifics about what the kind of follow-up support and the pathway, the journey will be, rather than generic terms like pathways?
Yes, so the MSF is looking at kind of post-diagnosis, how can we have a common set of expectations as to what patients, service users can expect, both in terms of ongoing treatment, but also in terms of the kind of social support and in the settings that they live in. So yes, we are looking at that fully as part of the MSF.
There will be specifics about what the pathway will be, rather than just recommending a pathway?
So yes.
Okay, thank you. And just lastly, and as you mentioned, you're aware of it, but access to kind of research and new emerging treatments, will there be kind of clear measures to provide access to those to patients?
Yes, so do you want to come in on that?
Yeah, I mean, the MSF is a work in progress, as you would have picked up from Emily's comments, but we're absolutely committed. We've got a task and finish group that's bringing together key partners from across health, adult social care, voluntary sector, and people with lived experience. And it's absolutely clear that the issues that you raise, Mr. Beals, are front and centre of how we're going to get a modern service framework for dementia and frailty.
And just finally, if those are in there, if people are happy, if this is the major step forward we hope it is, and we've been suggested it will be, clearly the importance of, there'll be an importance of implementation in the system. How will the MSF have teeth in terms of its adoption? How will the Dementia Czar, which has been talked about and adopted, how will that Dementia Czar have teeth? What powers will they have in ensuring the MSF is adopted?
My experience of being a minister over the last 2 years is you absolutely have to have targets and metrics, and you absolutely have to have a mechanism in place to monitor and ensure that those targets and metrics are being delivered. That's what I do across my portfolio. I have a monthly meeting with every one of the senior teams across, from GPs to pharmacy to adult social care, etc., dentistry as well. And the job of the minister is to ensure that when the system has agreed that this is the way we're going, that is the way that we have to go. And it's our job to ensure that we hold the system's feet to the fire and make sure that happens. So part of this, I think, is about leadership and about culture. Defining the targets, of course, isn't the be-all and end-all. You do also have to ensure that those targets don't become perverse incentives.
Big clear targets, leadership. But will there be any reporting on the MSF that's required from delivery partners to the centre? Will there be a reporting mechanism, as an annual publication of that data? Will the Czar have any powers? Or those may be mechanisms, but I'd be interested in what there will or won't be.
Well, I'll hand over to Emily on that, but the broad point I'd make is that where parts of the system are failing, you need to intervene and provide support to make them work more effectively. I don't think it's about sort of going around with a big stick and clobbering people on the head. It's about identifying where support may be needed, where some parts of the system are doing much better than others, so we eliminate all of that unwarranted variation. And any MSF worth the paper it's written on has to have those mechanisms in place. You've got to have a delivery plan, you've got to have a monitoring and evaluation plan, you've got to have a reporting back plan, and I fully welcome the idea of having the dementia czar, because I think that will give a bit of extra day-to-day force to the minister's ability to ensure that there's accountability in the system. But Emily may wish to add to that.
All I'd add to that is that just at the stage of development we're at with the MSF at the moment, having gone through the kind of evidence base for the different interventions across the kind of diagnosis, treatment, support, those questions about how do we report on metrics and the kind of role description of the czar is a very live kind of thing we're working on at the moment. It might be wise for us to kind of write back to you when those things are a little bit more clearer.
Thank you very much.
That's very helpful. So last set of questions. Minister, can I start by asking you to flesh out a little bit the comments that you made a bit earlier about your disappointment that the Chancellor and the Prime Minister had pushed the date. I mean, I think we share that disappointment, and the urgency couldn't be more real. Given that the restraint in the Casey Commission is that they can't recommend things that are outside of current spending plans, what's the Treasury got to do with this anyway?
Well, I think the Treasury had a particularly hands-on role in terms of phase 2 of Baroness Casey's work. So that is, fundamentally about how you rewire the funding of adult social care. And that's where the Treasury was very keen, I think, to put in a time frame which would effectively have meant that you're going into the 2029 general election with a manifesto pledge, rather than having agreement much earlier in this Parliament, with a view to, because of course, I mean, the reason that I just didn't agree with the Treasury's position on this is the closer you get to the 2029 general election, the more politically fraught and acute the debate becomes, and the less likely it is that you're going to get that consensus. So it was simply self-defeating. So we really need to look at that. Very pleased to hear Baroness Casey's views today that she's ready to move in a more accelerated fashion, and I would fully support that.
So to that end, I mean, do you believe that there is political will to deliver the changes needed as quickly as possible?
I am 100% convinced that
I believe you do,
yes,
but that's not really my question. I think you know that too.
Yeah, I think there is very clear public support for change. It is a deeply difficult and fraught situation for families who may have a relative or loved one who gets Alzheimer's relatively early in their lives, and you start looking at how on earth are we going to be paying for care for what could be 15, 20, 25 years, and there are others who are much more fortunate and not in that position, and I think everybody can see the unfairness of that. So we all agree, I hope anyway, that every political party in this place and every person who cares about their family and their community out there understands that you have to pool risks in life. You have to find a way of having fairness and social justice at the heart of how we pool risks to fund the public services that we need. And I think we can all start from that principle. Where I think where the rubber will hit the road is when when Baroness Casey does come forward with a proposal on the funding model, how we socialise that with the other political parties. How we do that. As she said, a lot of important work will go on behind the scenes. That we can't have all of those discussions out in the public. It's got to be, I think, a discussion between political parties in a very grown-up way about settling on a way forward and developing that consensus. And then I hope that there would still be time within this Parliament to develop that consensus, communicate that consensus, engage with the public and all of the key players, local authorities, voluntary sector, community health providers, how we tie it up with our neighbourhood health strategy. There's some really exciting opportunities to change the game here. And what I would just urge every political party in this place is to see the opportunity and not to weaponise this
Well, as you
issue.
know, this is a cross-party committee, and we do and are impatient for it. So just so I can really nail this down, because the way the terms of reference are written and say by 2028, if Baroness Casey she explained the national conversation, which may or may not be launched in July and over the summer, and it comes back and she gets conclusions by the end of 2026, let's say, if she wanted to publish them, could she?
Yes.
Right. So
Yes.
even though the Treasury and the PM, as then was, it looks like there might be change, who knows, but if regardless of what they want, she could and will publish, and she's got your blessing to do that? Is that where we are?
That's why I think the inclusion of the word by around the dates was very important. You have seen, Baroness Casey, she is not backward in coming forward. Mm-hmm. And this is an independent commission. I think that's also really important to stress is, there is a strong firewall between the Commission and the DHSC and myself. I mean, I've been involved in the cross-party talks, but I've had no involvement in terms of the time frame and the timeline. So there's no point setting up an independent commission and then not enabling it to be independent. And that's why I think it's so good that we have Baroness Casey, who's such an independent and strong voice, and she will bring forward recommendations as and when she sees fit. But of course, she does have to ensure that her recommendations are landed with the Treasury, landed
So
with
they
number
could
10.
still delay if they wanted to. There is still a mechanism by which they could delay this.
They could. I mean, there's little point, I think, of course, Baroness Casey's work is independent, but I think she would agree that there isn't a huge amount of point in bringing something forward which the entire machinery of government then doesn't agree with. So there's going to be a navigation process through all of this.
I suppose this comes back to my point about political will, but we'll see what happens at the top of government. Who knows? There might be a change of heart. And my very final question is, ordinary people out there who are currently perhaps looking for assessments or are worried mum and dad are getting to that stage, what tangibly will they see that's different by the end of this Parliament? If we're on our current trajectory, what's going to be actually different, not planned to be different? What's going to be actually different by the end of this Parliament?
Okay, so I started off by talking about quality, control, and joined-upness. On quality, care workers who are motivated, properly remunerated, and respected. Fair pay agreement, very important for that. On choice and control, unpaid carers, 4.7 million of them. What an incredible job they do in our society. We've given them the uplift, but we've also launched the review on paid leave for unpaid carers. That's an example of increasing choice and quality. And on integration, the much better work we need to do on the front door, the digital offer to people so that they're not being sent from pillar to post, and neighbourhood health. I think we need that really strong role for local authorities in the health and wellbeing boards, defining what an integrated neighbourhood team is and working with local authorities and care providers to ensure that people aren't going into hospital when they don't need to be there. One of the best way to deal with the downstream problem we have of delayed discharge is to solve the upstream problem, and that's through the neighbourhood health service.
You genuinely think all of that is going to be changed for everyone in this country by the end of this Parliament?
It is our responsibility to make that happen. In order to make it happen, we need everybody to roll up their sleeves and strain every sinew to deliver it. But I think that the will is there, the ambition is there, the desire to achieve those life-changing, quality of life-changing improvements for people is there. Of course, we now need to make sure that when we pull the levers and we make it happen.
Thank you very much. Thank you for your time this morning, both of you.
Thank you.
Well.